The Ministry of Health, Sultanate of Oman, is deeply honored to welcome you to this high-level side event on non-communicable diseases. Our gathering today is more than a reflection on progress. It is a call to deepen our resolve and accelerate action. Together, we will explore how political leadership can be translated into measurable commitments, how stronger accountability and reliable data can give those commitments meaning, and how inclusive partnership can turn vision into reality. On behalf of the Ministry of Health, I am pleased to extend our appreciation to our co-sponsors today, Philippines, Tunisia, Ghana, and Morocco. Without further delay, it is my honor to invite Her Highness Dr. Mona Al Said, the Assistant Vice Chancellor for International Cooperation at Sultan Qaboos University and Chairperson of the Oman National Committee for the Prevention and Control of NCDs, to deliver the welcome address.
Excellencies, distinguished delegates, esteemed guests, ladies and gentlemen. It is a profound honor to welcome you to this important side event, convened on the margins of the fourth high-level meeting of the United Nations General Assembly on the prevention and control of non-communicable diseases. Your presence here demonstrates our collective recognition that NCDs are not only a health challenge, but a major development issue requiring urgent attention and united action. Non-communicable diseases are the leading cause of death and disability worldwide, responsible for nearly 3/4 of our lives lost each year. They cut across regions, age groups, and levels of development, placing immense pressure on health system and imposing heavy costs on economies and societies. The challenge is universal, and no country can overcome it alone. It is only through global solidarity, shared resolve, and sustained political will that meaningful progress can be achieved. The Sultanate of Oman, like many nations, faces the growing burden of NCDs. We recognize that success depends on a comprehensive approach, strengthening prevention, ensuring access to quality treatment, and addressing the wider social, economic, and environmental determinants of health. Central to this effort is our commitment to equity, ensuring that all people, regardless of circumstances, can benefit from effective care and healthier environments. This work is also integral to the 2030 Agenda for Sustainable Development. Tackling NCDs is essential to achieving Sustainable Development Goal 3 on health and well-being, but its relevance extends far beyond. Reducing the impact of NCDs supports progress on poverty eradication, education, economic growth, and climate resilience. In short, it is inseparable from our broader aspiration to build inclusive, sustainable, and resilient societies. Our gathering today offers an opportunity to reaffirm our commitments, to share lessons learned, and to explore innovative partnerships that can accelerate action. With collective leadership and coordinated efforts, we can turn promises into progress and burdens into opportunities for transformation. Allow me, on the behalf of the Sultanate of Oman, to extend my sincere gratitude to all partners, experts, and advocates who continue to drive this agenda forward. Your dedication inspires hope, and together we can create a future where healthier populations contribute to stronger, fairer, and more sustainable nations. I wish you productive deliberations and every success in advancing our shared mission. Thank you.
Thank you, Your Highness, for your inspiring speech. Now, I am pleased to invite His Excellency Dr. Saleh Al-Hasnawi, the Minister of Health from Iraq, to give his speech.
First of all, I will thank you very much for Sultanate Oman for this invitation. And in Iraq, as well as any country in the world, we are facing a growing burden of NCDs, especially hypertension, diabetes, cancer, and the growing needs for mental health and addiction, both influenced by rapid change, socioeconomic, and environmental determinants of health. Against this backdrop, MOH in Iraq is working to address these challenges through the followings. First of all, expanding the expansion of early detection of program in the primary health care, including renal disease, hypertension, diabetes, and breast cancer. And also launching a national initiative to strengthen mental health, including integrating psychosocial support into primary health care and developing program and national strategy for addiction prevention and treatment and national strategy for suicide prevention. Also, strengthening the health financing and reducing out-of-pocket expenditure through the application of Social Health Insurance Act for the first time in Iraq, while promoting investment in digital health to expand access to health services. To conclude, Iraq reaffirmed its commitment to a whole-of-government approach to achieve SDGs and to reduce premature NCDs mortality by 1/3 by 2030. And at the end, my great thanks to Sultanate Oman and to all of your good self for making this event occur. Thank you very much. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Your Excellency, for your speech. My pleasure is to invite His Excellency Dr. Joe Atiana Bala, Minister of Health and Acting Aging from Malta, to give his speech.
Thank you very much to the Sultanate of Oman for this important initiative. Non-communicable diseases are a silent pandemic, preventable, yet definitely on the rise. Mental health is the foundation of our well-being and must be prioritized. Early monitoring does not cost much. It does not require high-end technology. It is rather about routine, organized, possibly opportunistic, physical and mental health checks across the life course. I would like to touch upon the political imperative for national screening programs. Screening for NCDs in primary care is a political choice, a choice to invest in prevention and early detection that will save lives, it will save persons from becoming disabled, and it will save money. Our political declaration calls for integrating NCD screening and early diagnosis into primary healthcare. Malta has established strong national programs with high participation rates. For example, over 70% of women aged between 50 and 69 take part in biennial breast cancer screening. Colorectal cancer screening for adults aged 55 to 74 achieves around 60% completion rate, and over the next 3 years, we are going to reduce the age of inclusion to 45. Cervical cancer prevention is advancing with primary HPV testing for women aged 27 to 60. Here it is important to note that HPV vaccination started in Malta in 2012 with girls aged 12 and above, but is now being offered to boys as well. Take-up of first and second doses is well above the 62.7% average, sitting at 81 to 87% in our islands. Since 2022, abdominal aortic aneurysm screening for men aged 65 has reached over 70% participation. Our forthcoming National Cancer Plan aims to expand screening services, to introduce genetic testing, and potentially launch new initiatives for prostate and lung cancer. Early detection of mental health issues is a core component of both our mental health and suicide prevention strategies. With investments in mental health first aid in the community in order to increase awareness in our citizens, community outreach, and integration of mental health into the primary care. So health is not just a ministry's responsibility. It is the foundation of every nation's and our global future. Prevention must not be a privilege for some. It must be universal, effective, and accessible. Every euro, dollar, or real invested in prevention saves many, many, many more in treatment and strengthens our societies. Thank you.
Thank you, Your Excellency. Now I am pleased to hand the floor to Dr. Shada Al-Raisi, Director of the Department of Non-Communicable Diseases at the Ministry of Health Sultanate of Oman, to moderate our first sessions entitled Driving Transformative Action on NCDs.
Thank you, Khalid. Good morning. Good morning, Your Highness, Your Excellencies, distinguished guests. It's an honor and pleasure to be moderating this first session. Now, much of what we have been talking about for the previous years were always about what works, what we know is relevant, what we know is recognized and well studied. So we have a lineup of presentations in this regard. everything from the role of primary care, as well as the role of fiscal measures, multi-sectoral engagement, and the very important and well-recognized WHO best buys as well. So it's an honor to invite His Excellency Dr. Ahmed Al-Mandari, the Undersecretary of Planning and Health Regulation in the Ministry of Health of Sultanate of Oman, to give the presentation, the first presentation.
Thank you, Dr. Shada. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. And good morning, Your Excellency, Dr. Hilal, Your Royal Highness, Sayyida Muna, Excellencies, colleagues, ladies and gentlemen. Thank you very much for joining us in this important meeting. And after hearing the inspiring remarks given by their Excellencies, I'd like just to share with you a few comments about why primary healthcare is an important issue when we talk about healthcare transformation, and at the heart of that transformation is the focus on the NCDs. Next slide, please. Next slide, yeah. Now, when we talk about primary healthcare and its importance in the structure of healthcare system in general, striving towards healthy and health and well-being of the population. This is the definition given by WHO, and in this definition we can see the key words, of what it means. Primary healthcare. It is a whole of society approach to health that aims to ensuring the highest possible level of health and well-being, which is equitably distributed among all population by focusing on people's needs and as early as possible along the continuum of care, from promotion, disease prevention, treatment, to rehabilitation and palliative care, and as close as possible to people's everyday needs or environments. Next slide, please. Now, there are three main sort of dimensions and pillars of primary healthcare and its service to the community. Number one, it is essential health service that is provided by the primary healthcare gate as close as possible to the people, to the day-to-day lives of the people and the population. It is multi-sectorial, engaging all sectors of the country, tracking wider determinants of health, as you have mentioned in your remarks, Your Excellencies, not only health, but also social, economic, environmental, even sometimes political. Third one is, empowering communities, making them to drive the whatever services and direct us to whatever services they need and the demands, and making them also accountable, as well as sharing and participating in design. Next. Why primary healthcare matters, as we all heard from the remarks and looking at the reports, either national, regional, or international reports, NCDs are on the rise, and plus with the aging population, emergencies here and there, and yesterday we have had an event about health and peace. Dr. Asmas from WHO Regional Office shared with us statistics about NCDs and the difference of rates of deaths and disabilities in emergency countries compared to non-emergency countries. Plus the inequalities that is happening around the globe in every system, with escalating costs of providing healthcare services, particularly to this group of population. It is only primary healthcare that can reach people where they live in a very cost-effective, efficient manner, leading to prevention, as I have mentioned, and also plus, identifying the sort of trends of diseases within that group of population. Next. Why we consider primary healthcare as a driver to transformation? Number one, it drives universal health coverage by expanding access, by making sure that every citizen, every person in that group of community or communities is having access to healthcare services. It reduces inequities by reaching the marginalized populations. It improves efficiency by lowering cost of hospitals admissions and providing the curative or rehabilitative or palliative cares. It strengthens trust, as people are getting access to all continuum of healthcare services in a very cheap manner, or cost-effective manner at the time once they need it. Next. Now in Oman, we have around 265 healthcare facilities that provide primary healthcare at different levels. We have 194 primary healthcare centers. We have 21, we call it polyclinics, and 50 hospitals that provide primary healthcare at different levels. Next. Now, when it comes into the primary healthcare services at the 3 levels, hospitals, polyclinics, and primary healthcare services, this is the way that we provide primary healthcare. In hospitals, we have local hospitals at a small city or town level. We have wilayat hospitals that are becoming as regional hospitals to a number of cities in the same governorate. We have extended health centers with specialty services. But at the same time, we have the basic primary healthcare services provided at that level. And we have healthcare centers, we call primary healthcare centers, that are either with beds or with no beds, that provide primary healthcare services to the population. The model now is to be transformed. It is His Excellency is leading a transformation and reforming of the healthcare system in the way we provide healthcare services. Next. Now, integration of management of diseases into the primary healthcare level. Next. NCD services in primary healthcare, we have introduced. Can we go to the next, please? We have introduced, management of diabetes and hypertension in a very integrated manner at the primary healthcare levels from the 1990s, with fully equipped services for patients suffering from diabetes, hypertension, bronchial asthma, and even screening for cancer programs. We provide influenza vaccines to those who need it at that level. We have, modern technologies that are integrated and introduced in the primary healthcare level by, for example, introducing continuous glucose monitoring systems for children with type 1 diabetes using the digitalization, system. We have, this chronic disease clinics that are supervising the management of patients who are suffering from different types of chronic illnesses, hyperlipidemia, thyroid disorders, and other NCDs, hypertension and diabetes as well. We have also services that are provided for, mental health services by identifying or early detection and management of common conditions through the primary health care like depression, anxiety, and other relevant mental health diseases. Next. When we talk about digital transformation, which is one of the main pillars of the healthcare system in Oman, and we have succeeded in that for the last 20, 25 years on, we have all now healthcare facilities and under the Ministry of Health umbrella are interconnected by digital system. Patients who are going to a primary healthcare center, they may go to secondary or level healthcare services with their records visible by their treating physicians in no time. And more development is going on to include more digitalized state-of-the-art technologies. Next. We have introduced artificial intelligence to enable identification of patients who are suffering from different diseases, like, for example, fundus camera, which is introduced as a trial in 25 healthcare facilities in Oman, with a central team supervising and monitoring these sort of photos that are sent by these cameras to a central sort of team, technical team, who's reviewing these sort of photos and referring the patients to the diabetologist for interventions. We have over 15,000 patients that have been screened so far from the beginning of this year in March until now. 15,000 patients have been screened by this technology, which saved us a lot of time and also saved patients a lot of wasted time to refer them for further management. Next, please. We have screening programs in Oman. We have, next. Yeah. We have introduced comprehensive NCD screening program in Oman from the year 2008 for diabetes, hypertension, hyperlipidemia, chronic kidney diseases, and obesity, with also the 5 factors that are leading to them. Next. Screening age threshold, it started from 40 to 30, from 40 years and above, but in 2023 it had been lowered to 35 years old, because we thought it's better to detect them at the early stages instead of just identifying them at late stages, which helped us in identifying them and referring them or offering them the management they deserve. Next. Breast cancer screening also, they have been this sort of service from the year 2008 for ladies at reproductive age group. We introduced also artificial intelligence by introducing these sort of services at a number of healthcare facilities, referring them to a technical team who's reviewing these sort of mammograms and referring them to the surgeons. And we have also introduced one spot unit in which 8 specialties are coming together to see the patient in the same day and making action at that spot at the same time. Next, please. We have nutrition also services provided at the primary healthcare services, run by specialized, well-trained, competent staff for those group of diseases and patients who are suffering from these diseases. Next. We have strengthening also programs for breastfeeding, which is introduced long time ago in Oman through the Baby Friendly Hospital Initiative run by WHO, and it really managed to increase, the breastfeeding manner for ladies who are, having their babies at least for 2 years, and the number of ladies using artificial milk or substituted milks is really reduced, for the last 20, 25, or indeed 30 years in Oman. Next. We have launched a new Omani guide for healthy eating that have been developed by a group of expertise from Oman, supported by WHO, UNICEF, and other UN agencies, and it has been really supervised and implemented by different sectors in Oman for that purpose. Next. School health program also was introduced a long time ago in Oman, and it is run by well-qualified nurses in each school, supported by Ministry of Education. Next. In schools also, this month, it has been decided last year, but from this month onwards, HPV was introduced, a vaccine. It has been introduced to school children from the age 15 and above, both boys and girls, as you have mentioned, Your Excellency. We have a lot of community-based initiatives. We have healthy cities, healthy villages, even healthy malls, healthy schools. And this is supported by WHO, and it is moving very well. The number have increased. Next slide. As you have noticed, you notice in the slide here, the number of healthy cities, villages, and also schools and institutes increased from the year 2000, from the 1990s, since the time that was introduced until now. We have a large number of healthy cities, healthy villages, and other institutes. It really helped in changing the mindset of the community and other sectors in the government by participating in promoting the health and well-being of the population in every community in Oman. Next, please. So in conclusion, primary healthcare is not just the entry point as we all look at it, and it is not only the gate saving the healthcare services. It is the backbone of our healthcare system. It is where prevention begins, as you have mentioned, Your Excellencies, where early detection of whatever health issues happens, and where lifelong care is sustained in a very efficient, cost-effective manner. When its three pillars, accessibility, comprehensiveness, and continuity of care, are strong, transformation is not just possible, it is inevitable. Strong primary care is the promise of healthier lives, stronger communities, and more resilient future of every country around the globe. I'm sorry if I took it a long time, but thank you very much for listening. Thank you.
Now, our next presenter, delighted to present Dr. Asmus Hamrich, Director for NCDs and Mental Health from the WHO Eastern Mediterranean Regional Office, who will be discussing NCD Best Buys in action.
Thank you so much, Her Royal Highness, Excellencies, colleagues, ladies and gentlemen. It's my great pleasure and privilege on behalf of the WHO Eastern Mediterranean team to be with you today. And may I say, it's also a great privilege to see the champion countries and the champions of primary healthcare and NCD prevention and control from around the world. And I'm acutely familiar with your experience and your seniority on the subject. So thank you so much for being here in this meeting with me. And thank you, of course, to the Sultanate of Oman for giving me the opportunity to summarize a little bit what is really a great global effort. And you have all had your involvement over the years with the NCD Best Buys in Action. And I also have some colleagues from other parts of the organization, of course, with me here. But since I'm based in Cairo and have been based for a decade now, obviously there's a bit of a focus to the Eastern Mediterranean region. I don't have to remind us, I think, of the 5x5 of what constitutes NCD and mental health focus areas, disease areas, and risk factors. We all know them from the political declaration that was approved 7 years ago in this building. And hopefully tomorrow we'll see a renewed and strengthened version of that. But you see, I hope you can, on the bottom right there in dark blue, the 22 countries of the Eastern Mediterranean region, which we all know is very diverse in many different aspects. And yet I believe, and we believe, that the Best Buys on NCDs actually serve all countries, rich and poor, and everything in between. So I would like to just say a few words there about the challenge in reaching the Sustainable Development Goal 3 on health and its related targets on NCDs and mental health. A few reminders of the UN and WHO. It's really joint effort, of course, NCD strategy and commitments, the good, the best, and the quick buys. Then our particular response in our very diverse and oftentimes challenging region, the recent initiatives of our regional director for the Eastern Mediterranean, Dr. Hanan Balkhi, who will join us in just a few minutes, I believe. And then the particular aspect that Dr. Ahmed Al-Mandari, my former supervisor, kindly mentioned in terms of looking at emergency settings in particular, and what it means for the future. So progress towards our target 3.4 on the probability of premature deaths on NCDs has unfortunately been stalling, I think, in many countries around the world. And we also see from this graph that there is an open jaw, so to speak, between what we want to achieve in green by 2030 and what across the 22 countries of the Eastern Mediterranean region in purple we are currently achieving. So clearly all countries of our region, all countries of the world need to further accelerate our efforts if we want to reach this target in 2030 as stipulated by our common sustainable development goals. So mental health is part and parcel of the 5x5 agenda, of course, now, and yet I think we're struggling in many settings around the world to tackle a very common set of diseases and illnesses and disabilities, and that's not different in the Eastern Mediterranean region, as we can see in this picture. And unfortunately, as in some other regions, the prevalence over time, the prevalence of mental health issues and illnesses in our region has rather been increased and not decreased over the last 20 years. No, the solution is at hand. We have, and I think we all try our best to bring to life to these documents, comprehensive both NCD and mental health action plans since 2013, and now both of them, of course, have been by the World Health Assemblies, by you, extended until 2030. So we know what to do, and part of the so-called Appendix 3 of the Global Action Plan on NCDs, of course, is you know, the set of best buys, the original best buys from 2013, which has then been updated a few years later by many expert committees from around the world, and has then recently also been refined, actually by a former colleague of WHO, Gordon Galea from Malta, and colleagues, and I think it's a very useful set. I'll say a few more words about it later. So I think it's important that we do remind ourselves what the House in this building decided 7 years ago in the political declaration, which I think really consolidated our agenda, broadened it to the 5x5, and asked for a lot of detailed effort, for example, in emergency settings as well. That then also lead, indeed, from the right side, the original best buy document of WHO of interventions, to the second edition on the left side, technical NCDs, best buys and interventions. It's an expanded list, but it's also a scientifically updated list. And I do believe the power of it is its universality, that it's really applicable in all settings for all people. And henceforth, it's a very important reference for everyone working on cost-effective interventions that I think we all know are not really asking for huge amounts of money oftentimes, but much more for the political will and the decision-making power from the top, from government, from institutions, to make it happen. So I think the area of work is clear. It's about the important risk factors: tobacco, alcohol, unhealthy diet, and physical inactivity. It's about the main disease groups of diabetes, cardiovascular diseases, cancers, and chronic respiratory diseases. And we have a distinction in those documents between the most cost-effective interventions, the best buys, and then the good buys, which are still very worthwhile, but with less of a robust cost-effective analysis. Now, what is interesting and important, that the Lancet, as I just mentioned earlier, only in February this year issued a very important health policy article on the so-called quick buys, which are basically 25 out of the 49 latest best buys that can be implemented by governments within 5 years. And I think it's critically important for colleagues who work in the world of finance and economics to see, this is also perhaps for, for my particular, domain, something that is actually feasible in our setting, even under the given circumstances. On the right, there's just a mini summary of the quick buys. And we have some handouts here as well, if you want to take them kindly at the end of the meeting, if you're not yet familiar with it. These are the familiar interventions, but I think the analysis behind it and the urgency of being, or the beauty of being able to implement them within 5 years usually is tempting. Now, let me say a few more words about the 22 countries of the Eastern Mediterranean, which are not really the Eastern Mediterranean. As we can see on the map, it's a historical term, but it's a very interesting and diverse group of countries, of course. And we have, with a lot of leadership from our country, from our countries, from our leaders in the office, also basically tried over the years, the last decade, really to condense down and to adapt the global action plans, the best buys, to what's now called a regional framework of action, which basically summarize the best buys, the strategic interventions, which also uses the progress indicators that we're using around the world, but which has some regional adaptations. It's a 2-pager. It's translated in all your languages and beyond. And whenever we go to countries, this is the basis of discussion that we're having. So it has been extremely useful, although you can call it a profane document as a 2-pager, but I do believe it has served us a lot of good. And it's going, as we can see in this form, all the way until 2030. So we don't need to argue so much about what we're doing, but we are already on the same page. Similar development on mental health. We have a mini summary of the Global Action Plan on mental health. Here, the best buys are a little bit more debatable, not quite as clearly spelled out often, but yet I think we all know, especially also as clinicians, what needs to be done, where the biggest bang, where the biggest disease groups like depression and so on lie, and what works. And this is again an attempt just to condense the Global Action Plan for the Eastern Mediterranean regional countries onto 1 or 2 pages. That also links with what I mentioned earlier, the new dynamics we got with Dr. Hanan when she came into office last year, and started 3 so-called flagship initiatives, one on human resources for health, one on access to medicines and equipment, but one very importantly also on action on substance use, which of course is categorized under mental health conditions. And as we all know, it's a very multi-sectoral issue, it's a complicated issue, it's a sensitive issue, it is stigmatized in most settings. And we are now really with the strong interest and feedback we are receiving from our countries, trying to also scale up activities there, and we just hope that we can also make a difference to patients' lives, to families' lives in many of those settings. I was reminded also when I picked up a Time magazine yesterday in the city on the US perspective of substance use and the epidemic, so to speak, that we have around us, and the importance. I think that as health professionals and leaders, we talk about it regularly. Let me just say 2 words also on what Dr. Ahmed Al-Mandari kindly mentioned already, the need, particularly in our region. We share more than 40% of all humanitarian aid recipients currently in the Eastern Mediterranean, unfortunately. We have henceforth tried to tailor-make our NCD work to emergency settings, really with our emergency colleagues, which is sometimes in UN organizations not so easy because we all work in our silos. And I'll be using in those frameworks, basically in this normative work, the 3 phases of preparedness, emergency response and recovery, using the health systems building blocks, but then looking at particular NCD and mental health, especially psychosocial support related interventions that are needed in the 3 phases of emergencies. And also look at even some of the risk factors like malnutrition. And I guess the beauty or the importance of this work is that we don't forget when the next emergency happens and the next pandemic perhaps hits, that there are patients out there in emergencies that need to continue their medicines and that need to continue accessing services. And this is exactly what we saw, I think, during COVID. And we even published on that. We did surveys in our region and beyond about the particular needs and the fact, for example, that oftentimes NCD and mental health were omitted or forgotten in COVID response plans. So I think it's a very real issue. And I think if we can use similar guidance, to make sure we're not omitting it in the future again. So to conclude, strategic priorities for the future, I think they're all in the documents. We have all been working on the draft, and you've been leading the draft political declaration development. In a nutshell, of course, what we need is to sustain and to scale up funding and financing, to have a strong focus on primary health care. And I'm so grateful that Dr. Ahmed presented before me, to look at the legislation, the governance side of healthier environments, to not forget emergencies. They're around the corner. They hit all of us in natural or other forms sooner or later around the world. To harness the power of data, and ultimately to work with people living with the conditions I presume many of us do in this room. They're just very common, and we need to listen to those voices. Thank you very much.
Thank you, Dr. Hamrich, and thank you for pointing out as well, where policymakers are often looking for those quick wins or those that produce their highest return on investment. The paper pinpoints exactly what produces these quick effects or have this quick impact. So thank you very much, Dr. Asmus. Our next presenter is Mr. Volkan Çetinkaya. Mr. Volkan represents the World Bank Group, and we're very happy and honored to have the World Bank here with us today. Mr. Volkan will discuss health taxes, improving health and generating tax revenue. Over to you.
Thank you very much. Your Highness, Excellencies, colleagues, ladies and gentlemen, it's really my pleasure and honor to be here with you today to talk about this very important topic. Today in my presentation, I will be focusing on health taxes. I don't have anything. Well, while the team is preparing my slides, I would like to mention that most of us, average people, we don't like tax, right? We complain tax when there is a new tax introduced or when the existing tax rates increased by governments. And often when we go abroad, if the country has really lower tax rates, we try to do some shopping. We try to buy our iPhones, electronics. Sometimes we stop at duty, shops to get some gifts, chocolates, and other things, because taxes influence our behavior. So that's why it's a very important fiscal tool to introduce people's behavior to make healthier choices. So that's what I'm going to highlight today.
Yes.
This one over here, yes, over here. Oops, sorry.
Yes, you're on.
Okay.
Great.
Okay, perfect. So today I will be talking about health taxes for societies, for our health. These are the good taxes that even though average people don't like, most of the taxes. So I want to focus on excise taxes that can be imposed on tobacco products, alcohol products, or in some cases, sugar sweetened beverages. How do they work? When the tax is introduced, it increased prices. Therefore, it reduced consumption. However, despite this, reduction in consumption, it increased overall revenues for the government. Because most of these products, especially tobacco and alcohol products, they have an inelastic demand. Which means that when you increase the prices, consumption is lower than that increase. Therefore, the overall revenue is higher for the government. But before talking about these taxes in detail, I would like to look at the NCD burden in Middle East and North Africa region. So as you can see in these tables, the tobacco is a really big burden for our region. And it has been decreasing in some of the regions, but unfortunately, it's not the case for the Middle East and North Africa region. And still, many people consume tobacco products. And even though the consumption of sugar sweetened beverages is relatively low, they have been increasing also quite rapidly. And as we all know, mortality and morbidity due to alcohol products is relatively low in our region compared to other regions. However, just looking at these regional averages sometimes may hide some important details that we should really pay attention to when we are designing and implementing our policies. So here, let's look at some of our countries in MENA region. As you see in the first graph, there's a huge difference in terms of the tobacco consumption in our region. For example, the tobacco product consumption is 4 times higher in Syria compared to Oman. And thanks to some of our
you.